And now we're sitting here and people are still saying we don't have enough doctors, we have too many wait times. So, we're still having those same challenges,
Hmm.
right? Which, you look at it. So we dug into this months ago, just to see what was the real story on this one because we were very interested. Get busy living or get busy dying. Good morning, Liam. How you doing, man?
Paul, great to chat with you.
So interesting week on the healthcare front, right? So you had Michael Hurley, who is the head of the unions, the hospital unions, came out and he's asking for $5 billion. So he's saying there's a shortfall. He mentioned there's a $280 million shortfall in operating costs for Ontario hospitals coming out of 2025, and it's growing dramatically. And now we're into this conversation again, which I thought we were through between the Ontario government, which is basically saying we have 60 hospital projects. We've brought in more doctors, more nurses. We put capital into this thing. We have a budget increase coming up of 4% for next year, 26, 27, that we put on the books. And they're saying it's not going to be enough. And we have to come up with $5 more billion for our hospital healthcare sector.
Yeah, I struggle to understand how there can be a shortfall. Like, you're talking about
Mhm.
5 billion added, but then even according to the Canadian Institute for Health Information, 2025 total spending was projected to reach approximately $399 billion. It's like,
Yeah.
how do you have nearly a $400 billion budget and you're saying we're running out here? That doesn't make much sense to me.
Well, and Liam, you did an article with your group, and a gentleman did a wonderful job on it. I picked it up. That's why I wanted to have you on the show, because I picked up this article. I thought it was a great article written, and it really took a look at how much Canadians pay
Hmm.
out of their income for healthcare. So, I'm a stats guy, so I jonesed on it right away. I was like, man, I like this article because it shocked me having lived in the US. I told you the story. I lived in the US, so I've been accustomed to US healthcare. I've been accustomed to paying for insurance, private healthcare. Now, I was lucky enough, this was years ago, right? Because I've been back to Canada. I'm born in Canada. I've been back here quite a long time. But when I was there, I was paying crazy low amounts for healthcare. Like, I was single, so I was paying a couple $1,000s
Hmm.
a year, and I was getting pretty much Cadillac healthcare.
Right.
I wasn't using it. I was a lot younger, quite frankly. So, I touch wood, I don't have any health problems. But yeah, I really wasn't using it, but I wasn't paying much. So quite frankly, it wasn't a big line item in my capital expenditures. But take us through, because I'm astonished now what we're paying and how much it matches up now with what I'm hearing Americans are paying.
Right. Yeah. So there's a study by the Fraser Institute which estimates that Canadian families, depending on the type and number within them, but pay between roughly 6,500 to 21,000 dollars annually. So I mean that's just massive on its own, and you look at how that has increased over time. The public spending from 1997 to 2026, the public healthcare insurance went up by 279%. So it is just we're funneling more and more into this system, and seemingly, like, I mean, yeah, when you look at what they're talking about, when it's not even enough as is, doesn't make sense too much to me there. But then you look at how those costs are split amongst the different families. So 10% of Canadian families with the lowest incomes will pay an average of $637. Families in the middle income group will pay about $8,600. And the families in the top 10% will pay around $66,000.
Oh,
So, yeah.
ouch.
And yeah, you're obviously looking at people, the average incomes of 450K and over for that, $66,000 bracket. But this is now a main expense. No, if you're especially if you're in the middle and in top income brackets.
Right. And we looked at, so when we did the budget show, I was astounded that this line item made up roughly a third of our total expenditures from a Canadian perspective. So when you're citing those numbers, you earn income, of course, that we all earn income. Hopefully all of us earn income. We pay taxes. A portion of that taxes goes as transfer payments to healthcare to the provinces, whether it be provincially or federally. And so that goes over to hospitals, healthcare centers, doctors. So that gets transmitted to them. And that's the portion that makes up that balance, right? That's how it gets calculated. Yeah.
Yeah.
No.
Yeah. It's a staggering number for sure. And then too, actually, one of the funny things, I guess, well, it's not too funny depending on how you look at it, but one of the payments that rivals healthcare spending now is interest payments on our debt.
Oh yeah.
So we, take on more and more debt to fund these systems, and then that interest just accrues.
Right. So it's interesting, Liam, because you look at this number now, and it's a big number. What was the total again? It was like
Just
300 and 400 billion.
399.
Yeah. So it's like a massive number in our, as we mentioned. And now we're sitting here and people are still saying we don't have enough doctors, we have too many wait times. So, we're still having those same challenges, right? Which, you look at it. So we dug into this months ago, just to see what was the real story on this one, because we were very interested. And I just wanted to, remind or review this with you again, because I found it really interesting the first time we did this show. So in Canada, we have roughly 100,000 physicians. That's our doctor pool, right?
Okay.
So, and we have 241 physicians for 100,000. So, and this is I think the beef that we find all the time when we look at it. 7% of them are rural and 93% are urban.
Wow, that's a big split. Yeah.
Yeah. Well, then that's always the problem, getting people, I just was doing a meeting yesterday, and someone from Scarborough was complaining about the fact that there's no doctors even in Scarborough now.
Wow.
So it's hard to get a doctor.
Centralized right downtown.
Well, they don't want to live there, so they don't go there, right? So to get doctors to go out is very tough. 54% male, 46% female. 57% specialists, and surgical, it's changing. But you look at this, and so we went through and we said, okay, where do we look for healthcare expenditures per capita around the world? And I thought, okay, we have to be at the top here or close. We're in the top 10. And we go back and forth between 10, 11, and 12. We bump around, but the U.S. is number one at per capita at 14,800. We're at 7,301.
Okay.
So we're half of the U.S., but we're side by side, almost equivalent to Australia, France, Ireland, Sweden. And of course, my pet peeve, I got to say it on the show. Sorry, guys. Norway, which is $9,993 a person, which if we would have made the right oil decision back in the 1980s and we would have had the fund, the wealth fund that they had, we would be above Norway. So those baby boomers that are sitting listening to the show, hey guys, I'm not trying to be difficult, but you got to take some responsibility. That was a bad decision, right? Because now we're in the point where we're saying there's a deficit, right? And is this this is a political to and fro we see all the time, right? This is like one of these crazy to and fros that we're going to go through. And the problem is the politics or the morphing back and forth between the unions and the government. It's a little bit like, okay, we'll support you, but we need you to put another $5 billion into this. And then the government comes back and says, we put enough into it. And this goes on. We saw it in Quebec. We've seen it in BC. We're now seeing it in Ontario. And this goes back and forth. The problem is that faction of baby boomers, that group, that large group of people who are aging now, and becoming into retirement age, they're valuing this even more.
Right.
So the unions are saying, hey, if you want us to really get on this and put this out there, you better put more money into it and pay us more money. So it's there's a lot of political to and froing here going on. And unfortunately, it's getting in the way of the right solution. So, and I've said this on other shows, the problem is, and I'm going to jump around a little at the end here, but, you know, if you look at places like Quebec, they tried to come up with a solution on this. So, Dubé, which was the minister Dubé, who actually had to resign, was the health minister in Quebec, and then Legault, Premier Legault. Basically, that was the straw that broke the camel's back in their careers, right? Because as soon as they said, "Listen, we have 2 million people without healthcare, we got to do something here," the doctors turned, and quite frankly, they were gone.
Wow.
Yeah, so this is a big political faction, and it really does toe a line. But now we're at a very interesting kind of intersection point, right?
Mhm.
Because here we are, the stats aren't really playing out. So, and I know they're saying there's a shortage, but you look at, as I mentioned to you, the expenditure per capita,
Right.
pretty much what everyone else is spending, right? So it's pretty comparative. We're not low. You look at the payments to physicians, right? And then you look at the average salary of physicians. So, and I did this with Jim Lang, and he was like arguing back and forth, we don't have enough doctors. We don't have enough doctors. I said, Jim, let's go through the math, okay? They make roughly $400,000 a year. So, if you look at it, a family medical GP makes about $324. Medical specialists make about $406, and surgical specialists on average make about $556,000.
Wow.
Yeah. Good incomes. Yeah. Well, and listen, I'm all for educators and doctors to make good money because I think they're important in our society for growth and productivity, right? We have to be healthy. We have to be educated. I'm all for those things. If the benchmarks and KPIs are showing we're making it work, right? So let's pay people because it's working, right? Let's not pay people just to pay people. There's no business survives that way, not in government or anything. But so here we are, and you look. So let's take the average 400. If a doctor makes 400,000 a year, so we kind of started messing around with it before the show. They work, say, 220 days a year. So if you take off weekends, you take off a couple of weeks vacation, roughly you're about 220 days. Then only 70% of their income comes from patient visits. So we said, okay, then patient visits, they make on a patient visit somewhere between $40 and $60. So I took the high end, right? I said $60. And then therefore, over a 21-hour period, for the 70% of their revenue they make, they have to see 21 patients a day. Divided by 8 hours is about 2.6 patients an hour.
So there, yeah.
Right?
Becoming a conveyor belt at that point, yeah.
Yeah, but if you look at it, and I'm sure there's longer and shorter patient visits. Person comes in for a cold, person has a medical condition that's really bad. You're going to take an hour, right? You're going to take 10 minutes. So I think on average, but definitely achievable benchmarks, because I think the argument that we don't. Then I went and took a look at the World Population Review, and I tried to figure out where we were from a doctor perspective. So we roughly have per 100,000 about, I think it worked out to about 28 doctors. But on the nurse side, we're at the top quartile.
Oh, wow.
We have 112 nurses per 100,000. So
right.
We have a lot of people supporting those doctors, way more than those. I mentioned those other countries that we were in comparison, the France, the other ones. We're way higher from that perspective. So we have a lot of support in our medical system, which I think is great. I think that's the argument that's starting to be made now, right? The argument that's starting to be made is we need to figure out a way to make this work, right? And so...
Well, yeah, I completely agree with you when it comes to, say, something like healthcare and education being extremely important. But even when you look at how we approach healthcare as a society, so much of it is like putting Band-Aids on bullet wounds after they've already happened. And so, yeah, we increase spending. We don't really have the doctor shortage, as you're pointing out, or at least comparatively to other countries. But I think it's just that we're becoming unhealthy at a rate that you can't keep up with. And I think that's where the real issue lies, in terms of, even if you just look at what most people are getting treated for, a lot of them are lifestyle issues. And so it's not just, random accidents, which obviously, you get into a car accident, you don't want somebody all of a sudden having crazy debt or anything like that. But then the fact that this system is also equally burdened by people that are not taking care of their own individual health along the way. I think the larger conversation always kind of misses that aspect. Like, what are we as individuals and citizens responsible for our health for as well? Because we're so
Mhm.
quick to offload it onto these systems. Like, these systems are responsible for our health, but along the way, we don't really take into account any of that. But I mean, even too, when you consider what we're paying, going back to say the $400 billion number, like, to put that into perspective against our GDP, which is just over 2 trillion, probably looking at somewhere around roughly 20% of our GDP is spent on healthcare. We've got the
Mhm.
doctors, but then you look at something like the wait lists that people have for surgeries, which are probably a lot more important in need urgency. But those wait lists are getting crazy. Like, average now 28.6 weeks to see a specialist, compared to 1993, where it would have been 9.3 weeks. So
Well, it's interesting. I don't know. You're probably following it because now, in the US right now, and I'll bring it up. Please don't cringe because I know when I say US that people go tariffs, but it's interesting. The midterms are coming up and you're looking at the Democrats and you're looking at what they're the socialist Democrats now they're calling them.
Mhm.
So, the very left Democrats and they're actually asking for our healthcare system.
Right.
And it's funny because on more American shows, you're now seeing them quote our stats. Canadians wait 2 months for surgery. They may wait 3 months. They line up at the hospital. So now the Republicans are actually using these stats that you have,
Right.
and they're actually from the medical associations across Canada, the Canada Medical Association, Health and Medical Association. They're actually quoting those stats. And so
Mhm.
they're taking them right out and they're saying, if you guys want this system, right, you're going to end up waiting this long. So you can have this system if you want to go with the left wing socialist Democrats. But the problem is you're going to actually have all these wait times.
Right. And I think
But
that's the where the real conversation needs to end up is not, do we have completely publicly subsidized healthcare as we do in Canada, or do we, completely privatize it?
mm,
Obviously, America has tried certain things like Medicaid and so on, but um, it's you look at places that do rank in the top of the world, places like, say the Norway, or also even to Netherlands, I think is really high up on that list. Most of them are running split
right.
systems, because it doesn't make sense. Like, if you have the money to pay for a surgery, let's say in you're a Canadian, well, you're looking at it going, oh, I'm not going to wait 28 weeks, half a year to even just see somebody, let alone get booked and have the actual surgery.
Right.
That person's probably going to go somewhere like America and give them their money.
And that's what they're saying. They're
Mhm.
saying, we have an onslaught of Canadians coming to America for surgeries they can't get on a timely basis.
Right.
Right. Now, it never used to be like, let's kind of put this into perspective because we're, again, I tell this story the other day on another show about governments being this slow moving boat or vessel, that basically makes decisions and slowly turns that boat or, is coming around, but the tide is moving away from them. Right.
Right.
And in this case, I think we all got really uptight. I know we did. When immigration after COVID just ramped up and, our systems like healthcare struggled to meet them. And now that's kind of changing. That's adapting and, people are leaving and there's a net, movement outside of Canada. So I think we have to be cautious. We throw the baby out with the bathwater. We got to be careful that, quite frankly, we have a system. It did work at some point.
Hmm.
So when I was younger, we had a fairly, decent system for Canadians. You never heard much. People were very healthy and happy about healthcare. They'd go to the doctor if they had a specialist appointment. They go to a specialist appointment. it was really never, we didn't see it much in the news, right? This
Mhm.
is a more recent thing. So, and I looked at when I did this show on Quebec. So it was interesting because I mentioned Christian Dubé and Premier Legault getting all this heat. And it really, they were caught between a little bit of a rock and a hard place. And I think no one really talked about it that much because there was so much pressure from the doctors and so much pressure. But they had a quarter of their population without a doctor.
Right.
So they had 2 million people, and in Ontario had only 83%, but we weren't saying much. But they were starting to feel the pressure of the population saying, listen, in order to get healthcare, these 2 million people had to go to emergency rooms and they had to sit there for hours and hours and hours. They weren't getting any medical treatment. They couldn't even get referrals to go from the emergency rooms. They were waiting 20 and 24 hours just to get seen. And then literally months to get, or even years to get specialist appointments.
Right.
In Quebec. So it really did get out of hand. And I think, when I was looking at it, there was a Fraser Institute report that said the medium wait time for a specialist in Quebec was 29 weeks.
Wow.
Yeah. So, they finally said, we got to do something.
Mhm.
And I think that's where we're at. So I think I'm going to come back to it again with you, Liam. I understand the desire to increase budgets. I get that. People want to be paid more. We have inflation. We have food inflation. We have housing inflation. We have young people entering. We have nurses and doctors that, want to buy homes, want to have lives, and they're seeing some of their spending power erode. So they want a salary increase. I understand that. I understand what the union's saying. I get all that. But the challenge right now is that the economic key indicators need the system to be right sized first.
Mhm.
So I think there's a opportunity for that to happen. So I don't want to come off saying I'm against people getting raises because I'm not. But I think there's an opportunity. But I think you have to go back. And I'm not saying that Bill 2 in Quebec is the solution because it didn't work, definitely, right?
Mhm.
So because the doctors hated it. But I think there were things in that bill, and I still maintain that till today, that I think, are worth taking a look at. And so if you can fix that system or our system, then I think you then start to figure out parameters with which to compensate people.
Right.
Right. And
I think one thing that has to be kept in mind when it comes to any public spending conversation, though, is because we are already running deficits, so and we have been for years on years now, and so any new spending by default is going to be debt driven.
Right.
And there's two options for that: either you sell bonds or you print more money. And so either by selling bonds, you pay more taxes in the future, or if you print more money, you cause the cost of living to go up again through inflation, right? By
Right.
devaluing the dollar. And so we look to these levers to give us short-term alleviation of a problem, but then it actually compounds the problem another year or two from
Right.
down the road. And then you're going to have, again, so you could debt finance more to make sure that doctors are getting paid more, but then a year or two when we feel the ripple effects of that, they're going to sit here and go, the cost of living went up again. And it's like, yeah, because it goes up with every debt spend. But to what you noted on the immigration topic that I think is interesting as well is it's not just the number of people coming into the country that overwhelms the system, but that we are doing that in order to fund the system. And so this becomes kind of a double-edged sword as well, where because if you look at, seniors aged 65 plus account for 47% of healthcare spending, and our birth rates since the 1970s have collapsed in Canada. And so what's been happening is, on any social program front, whether it's healthcare or any other one for that matter, is you need a wide base of taxpayers paying for a small tip of the pyramid for people that, retirees and stuff that need it. But
Right.
if that population inverses, then you've got a small number of people paying for a wide top, the pyramid
Yes.
pyramid flips. And so there's about, I'd say, 5 to 10 different major issues that are driving this both, well, from many different angles, the wait times, the costs, and so on. And yeah, so to to try to balance all of those at once is a tightrope for sure.
Oh yeah. Well, not an easy tightrope,
Hmm.
but it's interesting, and again, I'm solution based,
Hmm.
so not trying to any party because I understand the goals and initiatives of each of them, but I think and it was interesting. So don't cringe because I'm going to go through Bill 2 for a minute because I think Bill 2 in Quebec had some interesting ideas, right? And what it did is it actually changed the compensation for doctors, right? And it changed the compensation by having kind of a fixed hourly fee. So a fee for service. Right now, they get a fee per visit, right? For 70% of their income, and they have other sources of income, whether it be research or other projects work they have. Most doctors, right? So now they had a fixed fee per hour. They had basically a hourly fee per visit, and then they had a bonus component. So based on the number of people they saw and the performance and the outcomes. So they had an let's call it two quantitative measures to compensate and one qualitative. And so wasn't very well liked. I get it, right?
Hmm.
Because it was too much of a shift. But the one thing it did, and I think that's where it did have some interesting, it actually took people and patients and put them into categories based on their illness and assigned them to doctor pools
Okay.
and to
Yeah.
groups. So I thought the brilliance in that whole thing, it wasn't the payment scheme, it was basically the reallocation of people. So they did green, yellow, orange, and red. Red being major illnesses, high needs. Orange being moderate conditions, yellow being minor ailments, and green being healthy. So you know how you pick your GP right now. You're healthy. So quite frankly, you'd go into a green category and there'd be so many green doctors in your region to deal with your issues. And they would be a support group and they would be compensated by hourly. So they would get an hourly fee, 8 to 12 hours a day. They know they'll make money. So if you never go because you have fewer visits, that doctor doesn't have to be concerned about making sure he has a diverse patient list of people who are really ill, not so ill.
Right.
They're not in that because you think about it from a doctor perspective, they're in this weird situation where they have to kind of, you can't get too many healthy people in as your patients. And I don't mean that in a bad way because then they're never going to come see you.
Hmm.
You're never going to get referrals. You're never going to, get any research grants or the drug companies aren't going to work with you on any projects, because quite frankly, all your patients are healthy,
Hmm.
right? So you need kind of that wide range of patients to actually increase your compensation to hit it. That's the current kind of methodology, right? Or in this case, they were allocating you and you weren't at risk or as much at risk from seeing a decline in your income.
Hmm.
Didn't like it. Doctors didn't like it. I was so on it, quite frankly. I thought it needed more work, but you know what? It was the start of something that I think, quite frankly, as from across Canada, we need to sit down and look at, right? Because we're going to have, you hit it right on the head. We're going to have this big aging population that's, growing like this. New Canadians, whether they want to even stay, that's their decision. I just read an article about new Canadians who are arriving and immigrating here. They're not even having kids.
Mm.
So quite frankly, it doesn't appear that birth rate with that generation that's coming from a new Canadian perspective is having. So our one woman per child that current Canadians have is translating to new Canadians.
Right.
So
Right.
it's not picking up, right?
Hmm.
So I don't know if that's going to be the ultimate answer. I think it's a short-term solution. But if you're not going to have an increase in, the worker class to pay those bills, that's a whole thing that we have to figure out. But then, quite frankly, we're also going to, at the same time as we're trying to figure that out, we got to deal with a very big population that is aging into the 65 plus category.
Yeah, I completely agree, because this is unprecedented when you look at the population inversion, essentially, right?
Yeah.
This isn't something that our healthcare system has dealt with, and as you're seeing on the political front, what also adds further stress is that if something isn't, let's say, marketable on a election campaign season, then this might be something that we need to start considering now for 10, 15, 20 years out.
Yeah.
But if it's not going to get you elected next year, nothing's going to end up happening. But what would your thoughts be on, say, instead of something like one public system that then gets split into red, yellow, and green, but something more like let's say like the Netherlands, where you've got a public and private split, and then you've got the yellow and greens that kind of, hey, the public healthcare system is going to be here for the people that absolutely need it. They can't afford it, and maybe they're in that red zone.
Right.
But if you're in the yellow and green, if these are thought of as more kind of what you could consider, I guess, personal choices. They're not like this surgery or this medication or this illness needs to get to you now. Then that goes into the private system so that we can alleviate some of the burden off of the public.
I'm good with that.
Mm-hmm.
Okay. One condition, or maybe two conditions. Okay. So and I added this. No. And, I brought up Norway earlier on the show. To me, it's kind of this whole ball of wax that you now need to consider based on, you hit it right on the head, based where we are on our debt load in the country right now and our interest costs and our carrying costs. I think what you have to do now, and I know in September, the Prime Minister is starting to talk about bringing investment companies in to buy minerals and goods in Canada. I think you have to turn that into a solution that has a healthcare solution in it.
Mm-hmm.
So that's fine, right? If we're going to do that and we're going to get investment from around the world and more investment in Canada on our minerals and our resources and everything else, I think that Canadians need to directly partake in that to offset the cost of what's going to happen. So I think we're kind of at that TSN turning point where we haven't talked about it. And I know, we were okay. And I hit on the 1980s when we had Petro-Canada and we gave it up. Alberta went bananas, wanted it all privatized. Now, the biggest wealth fund in the world is Norway. And we have, $12 billion sitting in an Alberta wealth fund, which is like a pittance compared to the $1 trillion that are sitting in the Norway wealth fund that get used to subsidize healthcare. Right. So I think it's not too late. We still have an abundance of resources, whether it be minerals or oil or whatever it is, water. We have a ton of things that we can capitalize on. But I think it's now time to kind of turn it into a ball of wax and say, okay, we have an aging population. We have so much of this investment needs to be allocated for this. At the same time, we have to restructure how we do it, because if we're having an aging population, we have to figure out how to get them healthcare.
Right.
So we can't just leave this broad swatch of physicians and referrals. We know that's not working, right? So we do need to go restructure the way we do healthcare and how we treat people, because the population composition is so significantly changing. We just can't do it this way anymore. It's not feasible. And anyone who tells you that we can keep going on this path with the same treatment methodologies we're doing is totally out of it. Yeah. Like they just are not on the ground. They're not going to doctors. They're not seeing the implications of their actions, right? Mm-hmm. They got their head in the sand. So now, if we change that, and I'm not saying Quebec's perfect, so don't go bananas again, all of you, but I think there is a modification on the color zones that we need to look at. The funding model has to come from a source. Now, I don't think, to your point, do you have privatization of some of those services? Yeah, I think you can, right? So there are people in that. But then I think you have to look at some tax relief or a tax write-off for my. Right. So if I decide I want to go and I want to use private healthcare, well, then I should get a tax credit of X amount for it, right? Because I've taken the burden off. I've used my own money to take the burden off Canadians. I've paid my same income tax. You said, high income earners pay $66,000 for 2 kids and 2 adults on average for if you're over 450. right? 450,000 a
Mhm.
year. So those people, quite frankly, that's great. They pay a large amount of their tax base goes towards healthcare. So now, if they go and get on top of that private healthcare, give them a credit, right? And then allow more clinics to open up and more of that to happen. So that'll take some of the burden off. I don't think that's a bad thing. But at the same time, to your point, you got to be doing something with resources in our economy to actually fund it.
Mhm.
So you have to do a shift somewhere here because it can't stay static in my mind, right?
Well, and I think that's the biggest issue, because if we continue on the trajectory as you're saying, where the idea is to either just inflate, or cost of living goes up through money printing, or future taxes through debt financing, then you are looking at a scenario where those people that are paying $66,000 a year into the healthcare system, they have the mobility to up and leave if they
Yeah, why not?
just see that, okay, well, I'm just going to continue being on the hook for this thing. And that is so much of the messaging of, well, we just need to tax the affluent more. Well, if the affluent end up leaving, then where does that leave us with funding this system? But I think you hit an excellent point there as well, is that we need to find some sort of uh, first, I think it should be happening culturally through how much money we spend on publicly on media campaigns and PR, which you could essentially just call propaganda. It's like, why aren't we having mass propaganda campaigns about personal health, and to alleviate the system as well? But then also give people a tax incentive. Maybe have certain diagnostic tests, whether that be through blood work or even fitness levels of each generation, where, hey, if you can, let's say me as a 32-year-old, it's obviously going to be much more demanding than somebody that's 60 or 65. But if I can hit certain health markers that show I'm not in need of this healthcare system, bar,
Uh,
obviously an accident or something of that nature, but I don't have these lifestyle issues, then yeah, like incentivize people through tax breaks for that. Hey, if you can come here and do 50 push-ups and run 5 kilometers in under this time, then you get a percent. Obviously that's a little half-baked idea, but still something along those lines.
no, I don't. You listen. I don't think you're onto something. And uh, if and I grew up in another era, right? So, and you didn't see a lot of obese people,
Hmm.
right? So I grew up. I'm older. I mentioned to you, and just turned 60. So, but I did grow up in an era where there weren't a lot of obese people, not like today.
Hmm.
And there weren't as many people, not even close to as many people with diabetes and some of these crazy, especially I look at the stats now, 1 in every 8 person in America has diabetes. 1 in every 10 person in Canada has diabetes,
Wow.
right? So, and I look at it and I think to myself, okay, we must, whatever we're doing to people's health right now, whether they're depressed, whether they're eating too much, whether they're down, we are just, making these people struggle, and we're not incentivizing them to change the behavior,
Right.
right? But
Well, and
we're
it's even worse because we're promoting it in a lot of ways. If you look at, say, the public messaging over the last couple of years, you get, say, the big body positivity movements and all
yeah,
of this, and or even the push to classify things like diabetes and weight and all of this is like purely genetic. Obviously, people have certain predispositions to other things. I know people that it's really hard for them to gain weight,
right.
but there's zero conversation about what people should be doing in their personal lives. In
Yeah,
fact, it's the opposite. There's a campaign to say don't even worry about it, and
yeah,
we'll pick up the tab.
yeah. We'll pick up the habit there. Where other countries, quite frankly, employers are penalized if someone is overweight working for them.
Really?
Yeah, I think
Huh.
it's Japan. I think
Okay.
yeah. So there, and I was just reading about it recently, but and don't quote me on that one. But it was
Yeah.
I might have the wrong country, but there are other countries where they try to incentivize people to get their employees to be fit,
Hmm.
right? And so, but there are ways to do this now, and we know the outcome to it. And those are just another, again, those are as I mentioned, as if you revamp the healthcare system. So if you go in and you actually, whether you color code it, whether you actually put people in categories based on, if you're in the green category like you, and there's so many scans at certain ages, so you have to do your the following scans and tests every year to stay in the green. Else you go, and there's a tax incentive to you to stay in the green.
Right.
Therefore, okay, Liam, you got to do the 4 things this year. If your tests come out good, you stay in the green. Okay, I want that to happen. So therefore, I'm going to eat better. I'm not going to drink as much.
Right.
I'm going to maybe run a little more. Right. I'm going to exercise. I know you run a lot, but you know what I mean? Like, so like, therefore it gives me an incentive to do it. So, you're incentivizing, not penalizing. And so people will change their behaviors. Therefore, they'll go into a category and stay healthier longer, which reduce our health costs. All those things make sense. Right now, we're not doing any of them.
None of them.
None of them. None of them. And here's the crazy thing. And, and for those AI, geniuses out there, I'm going to throw that to you. Listen, you guys tell me all the great things you can do. You can do this. You can do that. You can do this. Change the behaviors of people and come up with a healthcare system that makes sense, that incentivizes people to stay healthier longer. I think you'd be a wonderful AI. I think what a program we would have, right? And what a good use of some system and intelligence to figure out. Hey, before we leave this, and I know, I always bring this up, but I want to talk to you about it before we complete the show. You got to clean up basically the honor system and billing. I know we don't. Listen, this is the one Canadians do not want to talk about, right? We don't want to believe that, every once in a while we get these stories. We got a lot of them coming out of COVID, these runaway physicians who bill lots of money. In 2025, the Auditor General of Ontario came out with just a scathing report, and we'll put it on our site. I'm going to put this up. I'm going to make sure if you want to read it, because I do encourage you to go through and read it. But basically, there were ophthalmologists who actually billed $6.7 million in fees for the year. And they said that they were doing 233 patient visits a day.
That doesn't math.
No, come on, right? We have diagnostic radiology physicians who are doing, the top one made $4.3 million. The average is $1.4 million for 90% of them, and one of them billed $4.3 million, saying they were seeing 930 people a day. Right? That's tough over 8 hours, right? You got to really be, Now, we had a family physician that actually billed 1.7 when the average one, as I mentioned, made 383,000, saying they did 600 visits a day.
Wow.
Right? So, and we have, this report, and it was very well done. It just went and said, listen, we don't have any audit procedures. Really, they've been eliminated. It's basically an honor system. There's no ability to recoup the funds if they're taken from any of the doctors and physicians. We got to fix the system because, as people hear this and it comes out more and more, if it's not changed, then the faith in the system will be significantly altered. People will not feel comfortable anymore. And you do hear this now. Like, as I go and I move around, these stories are like urban legends now. There's and people that, there was a time when people go, well, that he's a doctor, so, he makes great money. But now people are like, I know he's a doctor, but, he's maybe living too high right now. And because, quite frankly, some of these billings are insane.
Right.
And there's no capping on it. And I think that's one of the things we got to give public assurance on. We got to go back and make sure that the public is comfortable knowing that the billing system that is happening is being monitored, is being audited, and is being fair.
Right.
Because I think when you lose fairness in society, there's a whole bunch of degeneration, that happens over time, and faith. And if you lose faith in your professionals and your physicians because you're hearing these things, then what's next, right? You're right. Where do you find your healthcare? Because then, I can't go to him because, he's taking money. So how, he's giving me a prescription. Can I trust the prescription?
Right.
Can I trust the vaccine? Can
Is he
I
giving me
trust
this because I need it or because he gets a kickback?
Exactly. So there's all that, I call it tinfoil hat discussion. And I think we're seeing that increasing. I know in the States it's crazy right now, right? The amount of scuttlebutt online about what people say about physicians and drugs and everything else is off the hook, right? So, and part of that is because we don't have a system in place to audit that. And when I see that, when that came out, and well done on them. Like they really did, again, go through the read, because, you're going to, you have cases in here where you'll see specialists saying that they actually worked 365 days a year.
Right.
Yeah.
Well, and I think one of the reasons that you don't see much pushback against things like that is because the benefits, or let's say the profits that are being made from fraudulent activity, are so highly concentrated into a few people, whereas the cost of that fraudulent activity is dispersed amongst many. So
Yeah.
you've got a few people that are highly incentivized to push for these systems to keep operating, and nobody that is being pinched hard enough to really care about the fact that there's fraudulent behavior in them. And I think, as you're talking about, it's not even that it's okay. There's one sector, like doctors are, a bunch of people that are just trying to rip everyone off, or bankers are this, or, entrepreneurs are that, or the public sector is this. It's like what you end up getting is a small percentage of people that will take advantage of any industry. And actually, even if you look back at when this is a little bit aside, but I think the principle remains true when it comes to doctor fraudulent activity, is back during the safe supply era in, I believe it was the 1980s of Sweden. They looked at the fact that once they opened that up, and it went rampant out of control, just like we saw in Canada. When they did audits, they found it was like a select handful of people that were just like you're talking about with the billing.
Mm-hmm.
Most of that fraudulent activity was condensed to like 1 to 5% of the doctors. And so it's a small percentage of people that are taking massive advantage of those loopholes.
Yeah. And those are the ones we got to cut off, right? Because when you read those reports, that does, again, it hurts credibility, it hurts fairness. And those are the ones we got to get out of the system quickly.
You got to do something more than ask them what they want to pay back.
Exactly. Yeah, exactly. Well, and that's that's creating the mechanisms where, you have penalties for actions, right? And that doesn't exist today. And unfortunately, a lot of people know it. They use the system for their benefit. And here we are. So Liam, thank you. Let's get busy living. And thanks for taking the time.
Beautiful. Talk to you soon, Paul.
Looking for reliable and convenient personal safety products? Less Lethal has you covered. As Canada's only authorized Byrna distributor, we provide a range of products for recreation, protection, and security. Explore our Byrna launcher lineup, including the LE, SD, TCR, and Mission 4, designed for different levels of performance and protection needs. We also offer the Banshee personal safety alarm, designed to protect children, women, and vulnerable individuals. Because your safety is our top priority. Shop now at lesslethal.ca.